Hi, it's Henry Shelford from ADHD UK, back doing another deep dive, and this one is one of a series, and it's on ADHD myths. And as ever, it's the wonderful Dr. Shyamal Mashru helping me with it. Hello, Dr. Shy. Wonderful to have you here. Do you want to just introduce yourself? And many people would have watched other videos, but for those that is new, just tell us a bit about you.
Yeah, so I'm a consultant psychiatrist. I work both in an NHS ADHD service that I used to be the medical lead of, and I also have my own private clinic in central London, which is why you're probably seeing that under my name tag, ADHD Health Clinic. So you can also, if you ever want to look it up, it's www.adhdhealthclinic.co.uk. Today, Henry, interesting talk. It's both a fun and serious talk as well, of course. We're hoping to debunk some myths about ADHD.
And it's important, right? These are things that we often fight, sometimes internally as well as externally, because they're things that people have told us. And it's important to, just deal with the myths. So let's start with the big one. Is ADHD a real thing? Is it a medical condition?
Yes.
Well, that was short, and thank you for joining us for our deep dive series.
Well, no, so just to expand on this, obviously, right now,
This is because there are people saying it's not a myth. We've
yeah,
had
no,
a baroness recently saying it's just a fashion.
Yeah.
We had, that it's a fad. That we've had the deputy chair of the Conservative Party, then now part of Reform, saying ADHD is just people are just getting assessments to beat the benefit cap, that you can just acquire it for that. That's essentially saying it's not a real condition, that people just are labeling normal behavior. What do you say to people who say it's not real?
Yeah, so it is very much a real condition. It's a neurodevelopmental condition. We're now having a lot of extensive research being done. Research is still in its baby terms, or steps rather, because only up till I think, correct me if I'm wrong, but I think it's about 2008 where NICE guidance actually recognized this as a condition in adults. And prior to that, it was only conceived, really historically as the kind of naughty boy hyperactivity syndrome type thing.
Yeah, I think it's important for people, because you've referenced NICE. Yeah, so NICE recognised, and that meant the NHS formally recognised ADHD in the year 2000 for children, 2008 for adults.
Yeah.
And the 2008 for adults partly came about due to someone in a part of that NICE clinical group wherever it said child ADHD, they struck it out, wrote child and adult ADHD to start the conversation. They were the lay member. There would have been other factors as well, but it was a really important moment. But we were catching up. So in the States, ADHD had been recognised for many decades. And in the UK, it was first recognised by a guy called Sir Still.
Paradoxical, isn't it?
Yeah, and I think that was in around, I'd need to check, 1903 or 1904, around that sort of time. And that's when it was, first started to be talked about. But there is a sort of idea that if something hasn't existed forever in terms of our recognition, that then it can't exist at all. Like, what do you say to that?
Well, I mean, this is the thing, and also when something is relatively new, in terms of new means it's not obviously new, but it's only been, certainly in adults, as you mentioned, kind of recognizable diagnosis amongst healthcare professionals since 2008, which is not a long time ago. There's still more research to be done in this field. And I think maybe what also, certainly in the healthcare community, what adds to skepticism is, unless you have an abundance of research, which we are now seeing, of course, but we're discovering new things, as you do with any sort of condition in its inception. And when I say inception, it's not that this has always been there. but in terms of an actual diagnostic criterion, it's relatively new in adults. And so I think that's where you do start, with the other healthcare professionals, you start getting some skepticism. I think also, and we've discussed this in previous talks, of course, there is so much now awareness of ADHD, at least online. So social media, it's always in the news, etc. And I think also the other reason why this happens is because if you actually look at the symptoms, you see a lot of those symptoms in the quote unquote, say, non neurodiverse population. So, on the surface of it, people who don't understand the diagnostic criteria and how it's not just about counting the number of symptoms, it's about impairment on functioning in their life, it's about lifelong history of symptoms, etc., will look at that and say, well, then everyone must have ADHD. And I think that's, one of the issues as well.
It's a good. I wanted to pick up on a couple of points. So when you talk about new research, that's a very scientific way of speaking, which is that we've got, what you're saying is we've got a good lot of knowledge, but we're always trying to learn more, and we are progressing, and it doesn't undermine the actuality of ADHD that we're continuing to do research and we'll learn more. And I was thinking, as you said it, I was thinking around, say, for example, dementia.
Yeah.
So dementia not very long ago was just something people got.
Yeah.
We've now done more research. We understand it's not just a part of aging. We understand it is a disease.
Yeah.
We are starting to have an understanding that it's due to a buildup of amyloid proteins that there's plaque on in the brain, and that's what's causing it. And that's the new research. And it is interesting watching a physical condition with the public very quickly recognizing, yeah, that's different. Like it's not just old people recognize it's a disease, recognize it's protein, and at no point they're questioning, is dementia real, or because it's they immediately it's got recognized very quickly as a disease. And ADHD, when we're just not having that, it's like people are still challenging, is it a real thing? And then
and I think where the skepticism also comes in is this whole thing about, well, are people using it as an excuse? Are people using it for other reasons, etc.? And I think also there's been a lot of negative press about this in the media. It's funny, one week a newspaper will have a negative article, and one week they'll have, here's some interesting points to learn about ADHD. And I think because of that, that doesn't help as well, in terms of influencing public perception.
Yeah, it's, I think particularly say something like the BBC, like the bigger media organisations, they have multiple parts. So you have some individuals who are talking in one way and others talking another way, and it is very difficult.
It's mixed messages. So
yeah, and I think the discussions on social media, we get a lot of positive because people are learning what ADHD is, and that's a big deal. And they're getting an understanding. They use that as a leaping off point to go and learn more and come forward. But you do then have people who are devaluing the condition by going, oh, I've just, I struggle with a bit of concentrating. I forget things. I like, and well, I tell you, people will say, like, I've got ADHD, but I don't think I need a diagnosis. I don't really need. And you're like, well, if you don't need any support or help, then you don't, to my mind,
you don't have
ADHD because it's not having a debilitating. Yeah. Would you talk to that? So what do you, when you have?
I think this is really important. I can look at the inattentive symptoms of ADHD. I 100% categorically do not have ADHD, right? And I can look at the inattentive symptoms and probably could give you an example in my life where that has happened, maybe even 2 or 3 or whatever. There's more than that in the diagnostic criterion. And I know we're going to do another talk about assessments, but essentially it's a lot more than just counting symptoms. And I think that's where a good quality assessment comes in. But I know we're going to have a whole different talk on that anyway.
No, absolutely.
Hmm.
So, like, how does it work, like for the audience? So, with a physical condition, you go, right, this is wrong with you. Like you've got the pox. Your where's the body? Like clearly something's up. How do you define a mental disorder? How does it get decided? How is it the line between a disorder and life?
So, I mean, we are probably answering now, Henry, a question that I think I want to go into more detail, but I can give you the outline. I think, first of all, you need a suitably qualified professional doing the assessment, someone that knows not just about ADHD, but other comorbid or other mental disorders. You need to distinguish, is this ADHD or is this other mental disorders, or is it a bit of both? You need to distinguish the level of impairment of functioning in different domains of someone's life. So it can't just be affecting one area and not the other. I always laugh about this, but there's an interesting question in the symptoms, which is, do you struggle to sustain attention in sort of direct conversations? And I always sort of say, well, if it's only happening with your partner and not happening with everyone else, then that's not ADHD. That's something else. That's your relationship with your partner. I say that facetiously, but what that means is symptoms have to occur in every setting, or and persevere and happen across your lifespan, etc., and cause impairment in functioning. So I mean, we're going to go into another video, but it's much more than just counting symptoms. That's the point.
And so, but when you go, like, how did ADHD come into existence? So, like, a bunch of psychiatrists get together, and how does that work?
So there are a couple of big sort of diagnostic classification criteria used. So you've got the ICD-11, and you've got what we use often as ADHD kind of clinicians is the DSM-5 criteria. So even that is in a constant state of renewal. So you have a board of experts, and when I say experts, I mean people who are writing the textbooks, people who are doing multinational trials. They're doing research on, hundreds of thousands of patients across the world. They're putting meta-analyses together of different studies across the world, big randomized controlled, like, multi-centered trials. And that's where they're coming out with the diagnostic criterion. And even then, we know in the next DSM criterion, it's still evolving. Rejection sensitive dysphoria is not part of the diagnostic criterion, and yet it's something core that you see in adult ADHD. Emotion dysregulation is not part of the diagnostic criterion. It's something core that you see in ADHD, often the most disabling part for most people. So where I said it's a baby in research is, the research is valid. It's being done on big scale, but at the same time, we have a way to go. And where I would argue this point is, you don't ever deny the existence of cancer just because you haven't found the one pill that cures cancer. You know, um, everything in medicine is evolving. But I think that you shouldn't sort of discredit the information we definitely do know as fact. So, for example, how 60 to 70%, maybe even slightly higher percentage of people that were diagnosed with ADHD in childhood, it's not disappearing on your 18th birthday. It's going through into adulthood. And when we look at it now, I mean, when I look at that now, it was almost sort of unbelievable to think that how can a condition suddenly disappear when you're 18? That just doesn't make any sense.
It's a big deal. Yeah, it used to be thought it just disappeared.
Yeah, completely. And that doesn't make any sense. And actually what we're seeing is, and that's where the categories of subtype presentation comes in, it's evolving across your lifespan. in children, 30% of kids that are diagnosed with ADHD have got a significant the traditional hyperactive component to them. Many of those people, when they're followed through into adulthood, that hyperactive energy moves inwards. They feel internally restless, but they're not overtly physically fidgeting, yeah, because of social norms, nervous system maturation, etc. So it is a condition that might look different across the lifespan, and that's where it's harder to pick up, because it might look different to when you were 10. you know.
Yeah.
So we'll talk about this in our other video.
Yeah, well, look, and talking of being 10, that was myth number 2, which is ADHD just an excuse for bad behavior?
So there's a lot of it's a common misconception that people with ADHD are using this as an excuse. Genuinely, I've probably assessed and managed around about 8,000 patients, I guesstimated the other day, roughly that much. And from my own experience, it's absolutely untrue. So people will have described their school reports, for example, saying how they were not putting in enough effort. They were, essentially at parents' evenings, they were being, for want of a better word, being called lazy. When I meet these adults later in life, they're so distraught about this because they were sort of feeling like just misunderstood. That's the word that I hear a lot. I just felt like I was misunderstood, both by friends, by teachers, by my own parents. And actually, that's how rejection sensitive dysphoria appears, because that batters your self-esteem later in life. When you're living in a world where you feel misunderstood, it batters your self-esteem and you start questioning your own worth and value. So it's very different to, for example, prior to working in ADHD, I worked in the sort of what's called forensic psychiatry. So a lot of people with antisocial personality disorder, where they are essentially, a lot of them are not showing any remorse for quote unquote bad behavior. That's not the kind of patient you see in ADHD. And that's not the countertransference that you get in ADHD as a clinician. You feel sorry for people, actually.
And forensic, just for people, is generally means in the justice system.
Criminal justice system, yeah.
Yeah.
So it's a very different type of flavor. People feel terrible as adults. They don't feel proud of it, right? So therefore, it's not something that they were doing consciously and happy with that behavior. They just couldn't. I've had patients tell me they couldn't sit still in class. They realized later that they were making excuses to go to the toilet just to get out of the classroom and walk around a bit. It was just too much. And actually, the fidgeting often, even in adulthood, helps people focus. It actually helps them focus, the doodling, etc. So I think this has been a population of people, to be honest, it's a big injustice. They've been missed, and they're still being misunderstood and questioned now. And certainly when I meet this group of patients, in my clinics, you actually just genuinely feel sorry for them because they're really trying, So no, it's not an excuse for bad behavior.
And I think the way that you've personally expressed that, or essentially the way the research has been done, is that it is hard to understand the motivations of kids and fully understand it, although we're obviously getting better at that. But those kids grow up into adults, and then you can ask the adults, like, were you misbehaving? Were you like doing those things to make trouble, to get attention? And actually they're saying, no, I was really struggling. I was trying to work out ways to cope with the fact that I've got this boiling energy in me that I've got to release, that I need some kind of movement. And even like as an adult, I've got to move. Like if you ask me to be still, I have to hold myself still. It takes a huge amount of my focus. And it genuinely boils inside me. I really need some way to vent that energy.
Well, and it's not just always physical, right? So For
No.
many people, it's like that mental restlessness is the bigger one, right? So I'm saying people with diagnosed with very much an inattentive clinical picture, subtype picture as an adult, that energy, basic physics, as they say, energy can't be destroyed, right? It goes somewhere and it goes internally. And it feels like a mental restlessness. And that's where people get anxious. And that's where they struggle to focus. Because if you're really sort of mentally restless, it's hard to sit there and focus on one thing.
Yeah.
It's hard to sleep then at night as well, right? So it leads to all sorts of other issues. But yeah.
Myth 3 we've covered a little, but let's talk to it, which is that only children can have ADHD. You've already spoken earlier saying like it's just feels idiotic now, the idea that at 18 magically no ADHD. It'd be nice that like I always do find myself stumbling a bit when I'm trying to say like, you know, a percentage of kids with ADHD don't become adults with ADHD. If
I'll
anything,
explain that. I can explain that a bit actually, because there's been studies on
that'd
this.
be great.
What that means is, remember we go back to the first bit when we started to say the difference between counting symptoms and this being a medical disorder. What can happen over time is a small proportion of them, so this is children that might have met the diagnostic criteria in childhood but not in adulthood. We're talking about 20% of people that were diagnosed in childhood might not meet the diagnostic criteria in adulthood. Some people have actually developed lots of coping strategies, and actually if they were assessed in adulthood may not have the same level of functional impairment that they did as kids. Also, remember we spoke about how ADHD might present differently as you go through life. Let's say you're showing pictures of a more combined picture, which is inattentive and hyperactive impulsive symptoms in childhood, so the more stereotypical picture. You might move through to adulthood and you don't get so much of the physical fidgetiness, but you do get the kind of internal restlessness. You might have developed strategies to help you cope with that. And also, it depends on where you are in your life and what you do. You might have supportive partner. You might have workplace or sort of adjustments. You might have a very supportive employer. You know, people have a standing desk. All sorts of different things. They can have breaks, etc., etc., whereby not then impairing their function at work because the other adjustments are in place. And some of those people might not meet the diagnostic threshold, in which case they might have traits of ADHD. And actually, you put them in a different circumstance, it might be quite different. So it's a small proportion of people that won't meet the diagnostic threshold in adulthood, but there might be reasons for that.
And you talked earlier that there's partly the mental development that then means as a kid, certain aspects of ADHD you're not able to control, but you're able to control them because you have a level of maturity that's different. I thought it was interesting you talking about being in a place where you don't need support or having support, so you don't look like you're not impaired by ADHD. It's not having a debilitating impact, and certainly we see that points of change are often points where people really struggle, and they'll essentially going from a place where their level of support that they put in for themselves and other and that wider environment, and now they've changed. Something's changed, and now they're struggling, and that's because they had essentially had ADHD all the time, but it was managed in that circumstance, and it's not managed in this other one. Yeah, presumably you see similar things.
Yeah, and it's difficult actually, because this is the risk area in terms of where you have the quote unquote. I don't think Henry, you probably correct me if I'm wrong. I don't know if we use the term right now anymore, but the more higher functioning, and I don't know what the right word for that now is, and you can probably correct me. But for example, I've had patients who told me, when I worked for someone and I was doing a lot of the admin work myself, that was an absolute nightmare for me. However, now I run my own business and I have a manager that does my admin work. I'm more in charge of the creative direction of the business, and then suddenly they're flourishing because they've got someone else that's doing those parts that they struggle with. So that's what I mean by adjustments. And that's a whole topic of its own, which I know you probably cover in other sessions
It
about
is.
reasonable adjustments.
Yeah, and it's one of the reasons I hate the phrase and coping strategies, because who wants to just cope, and that we know we can be so much more, and so very aggressively trying to sort of stop that being an okay phrase. Um, Myth 4:
This is a big one.
ADHD, is ADHD overdiagnosed?
Yeah, so I've got quite a long
Don't
answer to
start that with yes.
this. No, absolutely not. It's actually has been misdiagnosed and missed is the bottom line answer. But there's a bit of background to this that I want to give actually, with some data. So um, I'm just going to make sure I get the data right. But I think it was the national. It was nice. And that, it was nice that came out with some data, and this what was part of the process of developing the ADHD task force, which I'm not going to go into because that's not, it's beyond this topic really. But essentially, they were looking at prevalence data for ADHD, comparing it to other countries in the world. This is sort of the beginning of 2024. This was happening, and they were essentially finding that in adults in the UK, the prevalence of ADHD in the population was about 3 to 4%, which is quite a bit lower than other countries like the US, for example. But what they did say was that when they were trying to look at the data sets, meaning going through records, it was probably underrepresenting the true prevalence, because it wasn't easy to get data records across a country. And that they estimate the prevalence to be more like 7 to 8% in the country, which is actually quite high. I know I'm not, my maths might be a bit rough on this, but I think that's probably what, 1 in 12, 1 in 13 people, which means if you're sitting there watching this, you will definitely know at least 1 or 2 people with potentially undiagnosed or diagnosed ADHD. So the prevalence is probably more like 7 to 8% at least. Now, other bits of data that's important is that there was a study done in Lancet, and I can't remember the name of this, but essentially it was in February last year, it was published, and it was looking at why girls might have, or girls might have been missed. So, for example, there's a gender difference here in terms of diagnostic rates. And one of the reasons is because a lot of the field trials and samples that were done when they created the diagnostic guidelines were based on the hyperactive schoolboy. So some of those questions that are being asked, there's a lot of weighting still in the diagnostic process towards that, rather than the inattentive schoolgirl that wasn't causing so much problems. And actually, that's why in my clinic, I generally see more women than men coming in as adults, because those people have been missed. In terms of misdiagnosis, there's been a lot of misdiagnosis. I give a lot of talks to GPs. And what I really want GPs to do is I want to see some audits from primary care, in particular, looking at all the patients that have been diagnosed with what they call treatment-resistant depression. So or treatment-resistant anxiety. So these are patients that were diagnosed with depression and anxiety, were put on, say, typical antidepressants. And those people who then someone thought, oh, this might be ADHD. And then they were put on ADHD medication a lot of those people don't go back to primary care for their depression and anxiety symptoms. Many of them wean off their antidepressants. Now, just a caveat, this is not me saying you shouldn't take antidepressants, but my point is there have been so many people that have been misdiagnosed with other conditions. I've had people come into my clinic that were diagnosed with bipolar disorder. They said, the mood stabilizer has done nothing for me because I stopped taking it and I've not had any relapse. And that's because emotional dysregulation has been misdiagnosed for depression and mania or hypomania. So that's bipolar disorder. Some people really struggle to manage these emotions and they might self-harm. If you have emotional dysregulation and self-harming and you're not thinking of things like ADHD, you can get diagnosed with borderline or emotionally unstable personality disorder. So I think, you know, especially in the depression, treatment-resistant depression, anxiety group, there might be many people that have been misdiagnosed. And if a condition was not even a condition, according to the national guidelines, until 2008 in adults, how would you consider it as a condition as a healthcare professional? You know, so I think people have been missed, people have been misdiagnosed. And we're starting to see that come through now.
One of the oldest people I know to get a diagnosis, they were, I think, 76, and their job in life was as a clinical psychiatrist, and
Wow.
they only recognised it. Their wife passed, and actually realised just how much she'd been doing to support him, and in doing so recognised his ADHD, but it was only then. And of course, he won't have been taught about it because it just won't have been a part of his training during his career. But it just showed. I thought it was interesting him being missed, and he was one of the people tasked with identifying it. Right. On ADHD being the myth of it being overdiagnosed in the UK, it's very clearly underdiagnosed, and we had some recent research in the British Journal of Psychiatry, a study of, I think it was 9 million GP records, and it very clearly shows underdiagnosis, which is something you've talked to on a previous video. Would you say the same of America? Is there under or overdiagnosis there in the USA?
I think that's a difficult one for me to answer because I'm not working in that sector. But what I will say is this. I can speak more about Canada than USA, and I'll tell you why I can speak more about Canada. When we look at the big conferences in this field and the big organizations, CADRA is one of them. That's the Canadian Association. And when I look at some of the real pioneers in terms of research, we definitely see that coming out of CADRA. So, Canadian guidelines, etc. I think we're behind. I think we're behind. If I can say that in the UK, I think we're really behind. And I think the area where we're
behind on knowledge and diagnosis.
And I think where we're behind, and this is not a criticism in primary care at all, but I think there needs to be more education in primary care, in general practice. And it's interesting because the Royal College of GPs have now put ADHD there as a extended role. So GPs can specialize in this, but unfortunately they haven't put together a proper accreditation program for that. And what does that training look like? But I think where we're behind in general, we're behind in terms of training other healthcare professionals about ADHD. And when there is lack of knowledge, that's where a lot of skepticism comes in. if, for example, people do audits and start to see, are my patients that I've been, maybe giving antidepressants to, suddenly saying that there's a massive improvement in their emotional symptoms, there's nothing more powerful than a patient telling you that, because that makes you as a clinician think, hang on, there's something to this. I think the proof is in the pudding, kind of thing. So I think in general, training, and not just GPs, I mean, just what healthcare professionals in the wider sense, beyond sort of psychiatrists, etc. I think that's where we're behind, in terms of answering your question, with US, etc.
Yeah, thank you. I think certainly what I've seen in the States is that if we take a sweeping statement, it's just not, it's too big and diverse a country.
Yeah.
I think it's likely, I think highly likely that there are some patches of overdiagnosis and wider patches of underdiagnosis.
Yeah, absolutely.
Yeah. And there's a very, very big difference between different parts. Certainly the numbers would lend to that. So is myth number 5, is it my parents' fault I have ADHD? Like, is ADHD due to bad parenting?
So the obvious answer is no. It's not due to bad parenting, but at the same time, I do want to bring up some other stuff here, around genetics and around trauma, in this field. Okay, so if we do know that, the majority of cases of ADHD, cause-wise, is etiology is genetics. Yeah, so it's running in families, right? So there's a few things here. So one is around genetics, and one is around generational trauma and generational patterns. Okay, so if it's running in families, there's a good chance that either mum or dad or both might have had either ADHD or at least traits of ADHD, which may have been undiagnosed. So where does that cause a diagnostic issue? Number one, we ask patients, do you have a childhood history of symptoms? So what do we tell patients to do? Can you give us an informant report? And we do this in our own clinic as well, because there's really no other way of doing this. Can you give us some objective evidence of childhood symptoms? Now, if, let's say, dad passed away now, mum was the one with the ADHD. What will mum say? Oh no, Johnny's absolutely fine. I talk more than Johnny. He's not overly talkative, right? No, I interrupt way more than him. He's completely polite, actually. Yeah. All the questions are going to be no. And then when I see Johnny in the clinic, I'm like, wow, this is barn door ADHD presentation, right? So that's one area. The second area is around trauma, right? Because trauma is spoken about a lot. Now, just to put it out there, I'm very much not of the Gabor Mate camp where everything is trauma and there's no such thing as ADHD or other mental health conditions. I'm being a bit facetious. I know it's a bit more complex than that. But where I think this does play a role, though, is you've now got an undiagnosed parent trying to deal with the stresses of a child with ADHD who's undiagnosed. So you've got the blind leading the blind. And I don't mean that in any bad sense, but I'm saying that colloquially, right? So that trauma in itself can lend to unhelpful patterns of behavior as they get older. And I know you don't like the word coping mechanism, but maladaptive strategies of how to cope, right? And so it's not about bad parenting, right? But maybe there's a lot of unconscious stuff going on because you just don't know.
Yeah.
Neither the
I think
caregiver
what you're clearly
nor-
saying,
yeah,
is it's genetic predominantly. So it's not, that's clearly not bad parenting, but the likelihood of parents having ADHD means that they may be struggling themselves.
Yeah.
And when you're asking questions, like, they think their world is normal. And so they're like,
You only know
this is
you
just
only know your
standard.
world. But if
Yeah.
you've got a neurodevelopmental condition that you've technically had since birth, you only know you. You don't look you don't know you as this is ADHD me and this is non-ADHD Henry. Henry is just Henry, right?
Yeah.
Uh,
And you've experienced the world through an ADHD lens.
right, but you don't know it's ADHD, and neither does your kid, right? So it's not bad parenting as such, but what I'm saying is if you don't know, it's a tricky area then. Yeah, so this goes back to the whole point about education, right? Of the community at large, which is what you guys are doing, but it goes back to education, and it goes back to generational thinking. This is also just on a side note, affects ethnic minorities, right? Different cultures. I'm from a Indian continent. I'm born in the UK, but my parents were not, right? And so if my parents had filled out forms, as let's say I had ADHD and my parents filled out forms, they'd be saying, no, this is absolutely fine. It was absolutely fine. Because it's just lack of knowledge, right? It's not anyone's fault.
Yeah.
It's lack of knowledge.
And we've seen the flip too, where a child's saying, like, I'm really struggling, I've got ADHD, and one parent is supportive of that, and then the other one who also has ADHD but doesn't recognize that, refuses to let their child go for an assessment because they're like, this is normal. Like, they've just got to sort of buckle up and get it done, and just not recognize how it's different for their child. So we can see that resistance. I'd say on the flip side, another flip side, we also see it where a school says that we think your kid has ADHD. The parents go and read about it. One of the parents goes, wait a second, this is me.
Happens a lot. I see those parents a lot in clinic.
Yeah. And so that's happening a lot. So, right, definitely not caused by bad parenting, but you can have parents who are struggling and struggle to recognize. Myth number 6, which is the last one for this video, which we've touched on a bit, but let's answer it specifically. Growing out of ADHD.
Yeah, I mean, we've mentioned this, but there's actually something that I have mentioned on a previous video, which is I think I want to bring in here. So we spoke about how about 70%, 80% of people will go through to still, say if you were diagnosed in ADHD in childhood, you would still meet the diagnostic criteria in adulthood. We also then mentioned reasons why you might not. So for example, you have adjustments in place at work and other places, etc., whereby you are no longer struggling in those domains of functioning. There is something that I just want to quickly touch on, which has been researched in the US. I think I brought it up in a previous video before, and I think it's still in experimental phases, but they have been looking at, actually, if you aggressively treat ADHD in children, in childhood and young as possible, that actually some of those kids might not, from a neurological perspective, show features of ADHD in adulthood. And that is something very interesting, because then you're talking about a quote unquote cure. And that's from a chemical perspective, from a biochemistry perspective. And I think that is very interesting. So I think this is being done in the US, if I'm not mistaken. I'm pretty sure it is. And essentially this is sort of really kids with quite severe ADHD. They're medicating them quite strongly from a young age, 6, 7 years of age, and really quite aggressively treating their symptoms. And interestingly, some of those children are then no longer, because as your brain is growing from childhood through to adulthood, you have this thing called neuroplasticity, you know, where the neurons are changing, it's evolving, your presynaptic, postsynaptic receptors in the brain, the chemistry is changing as you get older. And if you're medicating and essentially restoring the neurotransmitter balance, some of them are not showing it at all in adulthood without medication, which is absolutely, that can be quite groundbreaking, actually.
It's a big deal, and yeah, thank you for raising it. That's our lot for this video. We're going to do at least one more video on myths, so there's more to come, and probably two more, because I think it's such an important segment. Thank you as ever, Dr. Mashru. It's wonderful hearing from you. Obviously, your insights. If people want to see him personally, it's ADHD Health Clinic, which is, as it sounds, .co.uk. Do you have any final words for us? Do you want to sign us out with?
Well, no, I mean, I just think there's a lot of myths out there, but I think a big note, which I've mentioned before, this is a condition that's been missed or misdiagnosed. And I think if you, as an audience member, are querying this, and I'm not just plugging myself here, there's lots of other professionals out there, go and see an appropriate healthcare professional. Yeah, that's what
I think that's certainly our advice too. And one of the things we're fighting, obviously, is to get more accessibility for people. And thank you very much. I look forward to seeing you next time. Thank you again for doing these. For everyone watching, thank you for or listening. Thank you for being here. And obviously, it's got to say, we're a charity. We get no funds from government, and it is tough financially. Do consider donating, fundraising, being part of what we do. Thank you for listening. Thank you for your support. Thank you again to Dr. Mashru, and yeah, hopefully see you next time. Goodbye.